그러니까 알고 있는 건데 SF야 이런 저
Good afternoon. My name is Dr. Krishna Singh from Springfield, Illinois. I would like to introduce our co-moderator, Dr. Choi. We are all set for the final two cases from Asan Medical Center. So we're looking forward to having them take us out with a bang, if you will. Are they available at Asan?
Okay.
잘 되고 있어요. 조금 누워 계셔주셔야 돼요.
Good afternoon, Dr. Ando and Dr. Chung. So Krishna Singh and my co-moderator, Dr. Choi, we're here with an expert panel. Please, if you will, introduce the case and impress us with your clinical acumen and your skill.
Okay, thank you, Chairperson. I'm Hiroshi Ando from Kasukabechu General Hospital, Japan. It's a great honor to be given this opportunity. And so, would you introduce the case?
Okay, I'll introduce our case. This 85-year-old man was admitted for the treatment of claudication in his left leg. Peripheral angiography showed thrombotic total occlusion in left popliteal artery and anterior and posterior tibial artery. Ankle brachial index was 0.27. However, no definite wound in his left foot. Risk factor is ex-smoker and carotid disease, hypertension, hyperlipidemia, chronic kidney disease. Previously, he had undertaken common iliac arteries stent in his very tortuous left iliac artery and undertaken percutaneous coronary intervention 2 years ago. Risk factor, as I showed you, hypertension, hyperlipidemia, and ex-smoking.
Okay, so I'd like to change the wire to the regalia. Do you have regalia?
0.27 in his left leg. Could you show me the previous angio? Actually, yeah. Just 3 months ago, he had undertaken left iliac artery stenting and
14? Okay.
At that time, target region was left popliteal artery thrombotic region. And next, Dr. Lee underwent balloon angioplasty. And next, partially improved. And next, after bigger balloon angioplasty, I think this is final angio. However, you can find the multithrombus in his popliteal artery. And 3 months elapsed now, he felt claudication again.
Okay, so I'd like to show you today's procedure. Could you show me the first image? Can you see it?
Yes.
Yeah, so this is the first image. You can see a total occlusion from the P1 segment and the reconstitution at the next around P2 segment. And the system is ipsilateral approach because you can see a total tortuous iliac artery. So maybe it's impossible to cross over approach. So I try to puncture the ipsilateral femoral artery, and then I use commando wire. The commando wire, the tip rod is about 3 grams and have a nitinol core and a good durability with a microcatheter named Prominent. And next. Next. And I try to open the popliteal artery as an ordinary way, but it was impossible, so I try a loop technique next. And finally reach to the distal popliteal and peroneal artery. And next. After that, I check the angio. You can see subtotal occlusion of the peroneal artery. So from now on, my target region is peroneal. And then after dilate the peroneal artery, I will treat the popliteal artery. What do you think?
And one more thing.
Oh, one more thing? Okay.
Post-tibial artery was approved near total.
Oh, near total. Yeah, right.
Dr.
And,
Ando,
yes?
this is Dr. Rak. Good to see you.
Good to see you.
Yeah. So your approach is basically from ipsilateral anterior or contralateral approach this time?
Ipsilateral approach.
Contralateral.
No, ipsilateral.
Ipsilateral, okay.
Yeah.
And microcatheter? What's
Microcatheter is a prominent.
And why is command yes?
So I changed to the Regalia now.
Regalia 1.0?
Regalia wire.
Yeah,
14 wire.
Yeah, for the audience, I'd like to fix the one command. The command yes is 3.5 gram. And
About 3 gram.
Yeah, 3.5 gram. And yes. And this Regalia must be 1.0 gram. So
Regalia is 1.0.
Yeah, you are now just a quick wiring then to the balloon angioplasty. And what is your first option for the recurrent pamnitial occlusion? What will you do for the plan?
So maybe in this case, it was hard to pass the wire. So you mean like interluminal way. So maybe this picture was taken 2 months ago. So all the thrombus was gone and already become hard. So after ballooning, I will try stenting here.
What kinds of stent you prefer now?
So this is basically here's a non-stenting zone. So I'd like to choose a flexible stent.
Yeah, currently in the pamnitial balloon response is not favorable. In our country, we have 2 stenting options. One is the Viaban, the other is a Supera stent.
Okay.
I think that these days, if you can do it, the best way is to poor balloon response. You can try the Supera stent. The Supera 40 millimeter is available in Korea.
So I'm Dr. Chung-Ho from Taiwan. So my history, you said it's a thrombotic occlusion of a popliteal artery. So how long is the thrombus? A very fresh thrombus or subacute POD? What is the age of the thrombus? And do you use any protection device or thrombolytic agent during the PTA?
2.5 long. Actually, I don't have any experience to deploy the Supera stent because we don't have any spare.
Okay, Supera is now available in Japan yet, right?
No, not yet.
Okay. So
150.
any self-expand stent you have to do. However, in Korea, the usual self-expanding retinal stent, no reimbursement in the pamnitial area. That is a problem. Only one choice is a Viaban stent. However, Viaban, the profile is relatively big, and the ipsilateral anterior Viaban, you have to put at least 8 French. That is not good for patient. So if the 5 French sheets epsilon interrelated, another good option is 5 French comparable self-evident nitinol, the Pulsar 18. That is the only one very slender self-evident nitinol stent. However, whatever you want, I think the self-evident or the usual self-evident nitinol you can put over there. Then a little bit extending into the distal SFA, then we can escape from the pamnitia stenting, at least in the report. Then the reimburse is no problem.
Okay. So in my general practice, so I usually put try provisional stenting in SFA, but because especially tax CD region, there's a high restenosis rate, even though we use nitinol stent. Okay, let's try here. Okay, tariff. Inflation.
So this particular patient is has a different story. This is not de novo and recurrent restenosis, and you crossed by the subintimal tract. So balloon angioplasty alone will not guarantee for the long-term durability. So anyway, the choice stenting is difficult to avoid the stenting at this moment. So because of lack of SPERA experience, you have no choice. You have to do the self-expanding usual stent.
Actually, I'm thinking to deploy the SmartFlex because I have experience to use a SmartFlex several times.
So today's target is the popliteal artery. So in the panel, so we have to discuss about the optimal treatment strategy for the popliteal artery, just like this restenosis region.
Well, you've got actually this is already a reintervention for occlusive disease into the popliteal artery, which didn't work previously. Now I don't know whether a drug-eluting balloon was used in the previous time, but I do agree that you should do something more, but PTA only, although it's no stenting zone, and you should do the things which you're familiar with. In this zone, nothing is really proven. I mean, covered stent as well as drug-eluting stents. We haven't got series for the popliteal artery which are large, but ballooning only with DCB, I think there will be. Well, I don't know whether there's a lot of calcium in the distal SFA, but I suppose so when I see at the previous pictures. So anyway, you should do something with stenting. And then if you go for stenting, as you know, bare metal stents do worse than drug-eluting balloons together with bare metal stent or drug-eluting stents. You should make your choice for some drug-eluting technology if you want to keep it open.
Okay, thank you.
Do you think there would be certain technologies or certain methodologies that you would actually avoid, understanding that you wanted to make a decision that you do something more than just angioplasty here?
Yes, I would certainly do something more than angioplasty, and I'd certainly use one of the drug-eluting techniques over here because they've proven anyway to be better than the non-drug-eluting techniques for this area.
So you made the comment that you didn't see any fluoroscopic evidence of calcium. If you had seen some calcium, are you an advocate for vessel pre-treatment prior to the application of DCB?
Well, it's difficult to say. In the instructions for use of the drug-coated balloons, which we had till now, there was always in that we had to prepare vessels. Although in Germany, loads of physicians are treating SFA and popliteal disease without pre-dilatation. But I'm a believer of prolonged insufflation and preparations, yes.
Okay, let's go.
Yes, I understand that in Europe, although in the United States it's a regulatory requirement. I think a lot of doctors, I think last time we discussed this in the United States, one of my colleagues, half of people aren't doing it, predominantly for financial reasons. I'm always interested in wondering why people do things. Is it because they don't believe it, they don't believe the data, or is there a financial reason?
Well, as you also know, we have no reimbursement in some countries in Belgium either. in some countries in Europe either. As in Belgium, there's no reimbursement, but still we do vessel preparation, although the cost.
I think this kind of lesion, because it's a prior thrombotic occlusion. So me, if I was an operator, I would like to do the laser angioplasty first, followed by prolonged POBA, then DCB, then complete the procedure. And I think it's the most safe case. And maybe can also use a protection device to prevent distal embolization.
So is there any other opinion about the treatment?
I agree with the more conservative strategy for it, because it is a no-stenting lesion. But I still cannot understand in this case why there is just still thrombotic occlusion of the popliteal artery. I think we have to review all the medical history and the strategy to prevent the on-site thrombosis, because the on-site thrombosis peripheral artery disease is very rare. Most of the thrombotic event happens from the other side, like the embolic event, not on-site event. So if you find any thrombotic focus above, like the iliac stent or anything, we have to treat it there. Or if there's the outflow problem is still there, we have to open the distal occlusion arteries first before to put one more stent in the popliteal artery.
Okay, it looks like you've got a fair amount of dissection and some difficulty with runoff. Dr. Ando, we're going to switch to your other cath lab and tune in to Dr. Lee and Dr. Choi and Dr. Lee to introduce our second case. Dr. Lee, please introduce your case. We have my co-moderator, Dr. Choi, and an expert panel here to discuss your case with you.
We have prepared SFA to pulmonary diffuse total occlusion cases. This is Dr. Seung-Whan Lee. My name is Dr. Jae-Hwan Lee, and Dr. Kyung-Min Park will do the procedure together. And this 62-year-old woman was 72-year-old female was admitted for the treatment of claudication of both legs. The AVI was 0.70 for right side and 0.42 on the left side. She already treated the right side 1 month ago with DCB angioplasty. She has a risk factor for peripheral disease with hypertension, DM, and current smoker. The CT angiogram showed diffuse total occlusion of femoral popliteal of left side. Today's target is left side. I will show you the angiogram today. We approach it from the right side, contralateral approach. We engage JR diagnostic and exchange the guide wire to the stiff ampereage wire. Then 7 French anthesis was introduced to the left common femoral artery. And this is the initial angiogram taken at the knee joint level. She treated knee joint with knee replacement. So you can see distal landing zone is located on the P2 popliteal artery. And SFA proximal is diffusely narrowed, and the CTO segment is begun at the middle portion of SFA. This is today's angiogram.
So let me talk about we discuss about how to treat this region.
Yeah, this case is with SFA long diffuse occlusion. So we have to discuss about the treatment strategy. So intraluminal or subintimal approach or something.
Why don't we start at the end of the panel here with some get everybody's opinion about how briefly they would, given this imaging, given the patient situation, how you would address this situation. Go ahead.
Yeah.
I think procedure was approaches the subintimal method. I chose the subintimal method.
I think from the angiography, since you can see there's a tight stenosis over the proximal SFA, I think everyone will try the intraluminal technique to let the wire to go through the proximal portion. But which makes me most worry is about the distal collateral, because when we attack the lesion, the wire maybe will always go to collateral, and if I want to shift to subintimal strategy, they might have a problem there. Maybe at late point I cannot find a good entry point, but maybe I will shift to subintimal method anyway in the end, because it's a long lesion, but certainly try intraluminal first.
Yes, we initially started angioplasty with intraluminal technique with CXI, microcatheter, and common guide wire.
Anyways, we tried to the intraluminal approach with the support of the CXI. So, however, wire is easily going to collateral channel. However, we rotated the CXI tip and deeply engaged in the proximal cap, and the wire is going down. This wire is the command wire.
Change it.
So, and then some point we cannot cross the region, and we changed the V18. We tried to cross the intraluminally, and at this point we a little bit advancement. However, at this point there's some difficulty.
So do you think it's still intraluminally or already subintimal?
I hope.
We don't know about it, but we checked the rotational angiography to check the position of the guide wire during the procedure.
But at this point, when you were over this collateral, it doesn't really matter where you are. You just have to go and proceed and find your re-entry, whether you're subintimal, yes or no. I don't think it's a big point. The other thing is, I think it's very important that you use a measuring tape as to make sure that whatever you use, you always have your references to the previous image. It helps you quite a lot in doing these cases.
So I'm actually quite surprised at the absence of fluoroscopic evidence of calcium in this patient. Although she, I understand, is not a diabetic. She's 72. The CTA, you see contralateral calcium. How do you approach, if this was to be, fundamentally, how do you approach the presence of calcium versus the absence of calcium, and how does it change the way in your pre-procedure planning and your device use?
Well, as far as calcium is concerned, I don't think it's a big trick in recanalizing. We don't have reimbursement for laser or other recanalization devices, so we will always try and wire everything, which we succeed quite a lot. I think it's very few times we need recanalization devices for these things. On the other hand, late trials show us that if there's absence of calcium, that DCB and bailout stenting is the way to go. And when you encounter quite a lot of calcium, it's more in favor of drug-eluting stents or debulking devices, but we don't have them in Europe as they're not reimbursed.
So, we always try to be data-driven. At Charing Cross just yesterday, they presented the CTO arm of the Impact SFA Global Registry. Interestingly, long CTOs, what would you estimate would be the provisional stent use and the one-year primary patency rates in CTOs treated with DCB?
Well, the long lesions which were presented by Zeller in 2013, even in retrospective, showed us for lesion lengths of 19 centimeters, a patency rate of 78% with a provisional stenting rate of 18%. So that is already a mark. But the data of yesterday, I don't know.
So I think the point is here that we don't have very good results, actually, without using combinations of therapies in treating task C and D lesions with or without calcium.
Yes, Dr. Lee?
Yeah.
So, what's going on?
As you can see, the wire is nearly approaching the distal lumen. However, there is some gap. So at this point, we decided another strategy. So maybe intraluminal approach needed the more steeper wire, or the retroid puncture is required at this point. So
because the gap between the vessel and distal tip of the guide wire is very long. So I think it seems maybe very difficult to re-enter through lumen with antegrade. So it can make more damage to the pulmonary artery, and it makes make a dissection distally. So we chose retrograde approach from the anterior tibial artery because the patient has a healthy anterior tibial artery there. So we punctured anterior tibial artery.
So you did it.
Yeah.
Don't you consider like aberrant entry device or make another subintimal route again?
Yeah. So re-entry device makes a dissection more distally to the pulmonary artery. So, and this patient has also disease at the distal entry point at the pulmonary artery. So we punctured anterior tibial artery while keeping her foot with internal rotation and lateral projection of the contrast, make a single line with the needle and artery. Then you can see some pinching sign of the contrast during the advancement of the guide wire, advancement of needle. You can see some pinching sign. That means pinching of the artery. We check the lateral projection with the depth of the needle and artery. Then we inserted the guide wire safely. You need just
what kind of guide wire do you use?
This is a command ES guide wire, directly used. Then we did a C-series technique with a short 90 centimeter CXI microcatheter. Then we reach it to the distal entry point, distal landing zone. This is an angiogram taken by a microcatheter tip.
Well, I think you're making a very good point. When you're used to go in retrograde, we always try 2 times to go orthograde, but when we don't succeed in another plane, we just go to retrograde puncture, which gives you quite a lot of facilities, especially because you went down with your guide wire already till the re-entry point. So it will be quite easy to get up again. And second thing is, I think the command is one of the best ones to use for retrograde puncture because it has enough stiffness and gives you a lot of support from below. What kind of device do you use to support your command if you go up?
This is a CXI, or 18-inch comparable microcatheter. And initially, command guide wire couldn't pass the distal hard cap. So we changed the guide wire to the V18. Then we passed the distal entry like this, and the guide wire is passed subintimally with a loop, like that. This is a current situation. As you can see, there is a gap between antegrade wire and retrograde wire with a spiral position. So we're going to do a reverse cut for externalization of retrograde guide wire.
Dr. Lee?
Yeah?
This is Dr. Ra.
I know you. Your voice.
Yeah. So one thing I'd like to give comment is that the retrograde entry point. So for my usual practice pattern, I'm prefer to do the proximal 1/3 of the ATA instead of the distal. You puncture the relative distal because some case of retrograde 14 or 18 system cannot negotiate effectively. It particularly very calcified SFA region. Sometimes we need a 3-5 system subintimal retrograde approach. In that case, we need 4 French sheaths or 4 or 5 French sheaths, and sheaths can be inserted in mid portion of the tibia. So something that kind of possibility is better to attack from the proximal ATA instead of the distal ATA. So that is the usual operators.
I don't think the puncture site is not important. I don't think so.
This case is not a problem, but very tough cases, it's better to make more residual room to choose other device. That is the usual practice pattern. And instead of the V18 loop is making a relatively bigger loop for the retreated subintimal tract. So for my case, I prefer to use the other slender small loop wire to negotiate. And then intraluminal retreated wiring is also efficient, like a connect flex 18 or any other stiffer wire. You can negotiate from the you can reduce the subintimal tract length and just draw directly recanalization, even by cut or reverse cut, anything.
Yeah, good point.
For this patient has a disease at the proximal ATA, so we puncture the distal portion of ATA. 잠깐만. Dr. Seung-Whan Lee is doing an integrated balloon angioplasty. While he's doing integrated angioplasty, I'll do the retrograde wire passage.
We simultaneously approach each side.
I change the guide wire with command. Okay, the direction is very nice. Well matched. Okay, 우리 가자. 저장하고.
저장.
Control save.
Okay.
할 때 봐요.
할 됐어.
저장 안 된다. 다시. Okay.
So, a little with Dr. Jae-Hwan Lee and integrated balloon angioplasty.
제거해줘요.
So we
다 제거해요. 전부 다.
So we remove the integrated wiring in balloon.
가이드 좀만 빼줄래요?
Okay. So.
Oh no.
Oh
my God.
Somebody.
No problem.
No problem.
We can solve. This is
okay, no problem.
This is real life.
No. 그게 아니야. 맞나?
This is real life.
Real life.
Okay.
Yeah, there you are. As you can see, there are many ways to go through Rome, and some people try to avoid getting retrograde. On the other hand, some people also try to use some supportive catheter as to avoid loops in an O18 because they can be quite stiff and they can do quite a lot of damage. But to use what you're used to is actually, I think, or to use the tricks and tips which you're familiar with is actually one of the bases to go on.
Okay. Okay, now we insert the digress catheter.
So, Dr. Lee, we're going to leave you momentarily and go to your colleagues next door in the next lab, and we'll be joining you in a little bit. Thank you very much for that demonstration of an excellent retrograde technique. Dr. Ando, please.
Previous and one more.
Dr. Ando?
Yes.
Yeah.
One more back.
So all procedures are done, or?
Yes. So I'd like to show you the procedure. Back to the before pre-dilatation.
At the first column.
So back. So after dilating the peroneal artery and the popliteal artery using 2.5 balloon, and then I change the balloon to the 4.
Yes.
Yeah. So 4 millimeter balloon, and after dilatation, next. Before back. After ballooning, you can see the residual stenosis here. So I decided to deploy a stent. This is a Smart Flex 5x150, and a post dilatation using 5 millimeter balloon. Next.
So you did put the stent in the P1 and P2 area, right?
Up to the end of the P2, it looks like.
It's not my standard procedure, but in this case, it can be helped to deploy a stent. And then you can see recoil at the peroneal, so I try open up the peroneal again. Okay, let's go. 6, 8.
This patient has a wound?
Small wound.
Discoloration on foot.
Store. 10, 12. Okay.
12.
Dr. Ando,
or 2 minutes.
Do you want to try to open the anterior tibialis artery to improve the distal outflow?
So after opening up the peroneal artery, I'll check the below the knee image again, and I may try to open the posterior tibial artery if I need it. Anteriotibial artery, distal anteriotibial artery flow is not so good, so maybe it's hard to open the anteriotibial artery, only antegrade approach. If I try to open the anteriotibial artery, we need maybe distal puncture.
But you're making a very good point, because I think one of the reasons it occluded lately was because of outflow. We had quite a tricky outflow in the previous procedure. So if you don't do anything about outflow right now, you might find yourself in the same position, having a stent in P2.
So to that point, would you spend time, if this patient, she has, as I recall, both her 18 or PT out, would you spend a lot of time opening as many arteries as possible, or are you strategic in the amount of runoff you desire, relative to your point?
I don't consider a peroneal artery as being one of the main arteries going down to the foot. So with only a peroneal artery and the situation we started with, I would certainly try to get or anterior tibial or posterior tibial open down to the foot in a Rutherford 5 patient like it was.
So I would agree with you. Obviously, the peroneal, given particularly in a diabetic, what the collaterals of the ankle would be like. But I mean, so many times we find as interventionalists that we get down to the ankle and for some reason we stop. Understanding is sort of like a dead zone into the foot, unless, in a very complex procedure like this. How much do you pay attention into the runoff into the foot, understanding that you may actually stop at the ankle? How much do you image into the foot, and how much do you actually go into the foot during a procedure like? And this apparently is a claudicant, but she's got an ABI of 0.2. How do you address it?
But she had some wounds. That was them they just mentioned. So anything that's more than Rutherford, anything that's more than rest pain, I think you should take care. And if it's a very important lesion proximally, you can treat Rutherford's 4s only with proximal lesions. But whenever you go to Rutherford's 5, you should have one artery at least down to the foot if possible.
See, this is an example here, right? You have a good run up to the ankle, and then I don't know if that's a function of just our imaging, but it looks like we sort of stop here at the ankle here.
And there's very slow. There's collateral flow to the foot, but it's not really down to the foot. So I would spend the Rutherford 5. I would spend some time opening something more up down below. Yes.
Since there is already a stent there, so maybe even if it is a Rutherford 4, we think we still need to open as much distal flow as we can, or else stent thrombosis will be a risk in the future.
In Asia, I understand people are they use, particularly in Japan, skin perfusion pressure, the SPP. That's something in the United States we haven't used a whole lot, and I understand quite a bit of literature in Japan would suggest that that's actually a fairly good surrogate. Do you use SPP in Belgium?
No, we work on ABPs. We first for trials we will sometimes do, but it's quite cost consuming, and there's no reimbursement for it, so we have to do it on our own expenses.
I think that's something that we all struggle with. These non-invasive tests. We actually went through the failed trial of Impact Deep, which actually enrolled a fairly large amount of patients, 4 or 5s predominantly, and we made some correlations between ABIs and actually angiography and compressibility. And as you can imagine, there was no correlation between ankle brachial indices. Many laboratories in Europe wouldn't give us toe pressures, and no one did PPGs. So at the end of the day, we actually don't do a very good job in the non-invasive assessments of perfusion to the foot.
So, Dr. Ando, you successfully performed the balloon angioplasty on the peroneal artery. So, what is the next plan?
So, I'd like to open the posterior artery.
But this case is claudicant or critical limb ischemia?
Rupture?
This is a small wound.
Just a small
wound. Yeah. But PT proximal, we can see some stump. So Dr. Ando wants to recanalize, right?
Yeah.
That is good for patient because both wound and also recurrent restenosis, the once distal outflow became more brilliant, then the primary patency, the chance will be increased. So outflow clearance, the more the outflow patency, that will be good for patient.
Yeah, to get a good distal flow and then to treat the wound, just balloon angioplasty to the peroneal and the PTA and the ATA. So according to the angiosome concept, we can do PTA to more lesion as possible. So, but I think maybe there is a debate on the treatment of the popliteal artery with stent, bare metal stent, just bare metal stent. So in Korea, a superior stent is available. So maybe in my case, I would use the superior stent in this case. But what do you think about that? Other panel, so there is no other opinion?
And now in Taiwan, we start to have supera, so certainly for this kind of lesion, we'll use supera. If in the past we have to put a stent in this area, we found that zero PTX doesn't work. It always results in restenosis and then rescued by a wire-bound graft stent. So wire-bound may also be applied in this popliteal lesion.
So we can use the Bayaban or Supera or DB.
Yeah, but certainly the stent is needed. The first choice certainly is Supera.
Is it possible?
Very good, Dr. Ando. We're going to go back to your colleagues, Dr. Lee, and Choi, and the laboratory next door to you. We'll be back to see how you're doing in a little while. Thank you very much.
Thank you. Where is the wire?
Okay. Dr. Lee.
Okay.
So what's going on?
Yes, guide wire was externalized with a control radar guiding catheter, JR, like that. 안 나온다. Anyway.
Okay.
Okay. Then
this is a Coyote 4.100 balloon pre-dilated in popliteal artery, and this is distal SFA. Serial balloon dilatation was done, and after that we checked the status of the balloon angioplasty. Some flow is you can see. So we wanted to put balloon dilatation with the 5.0 from the P2 level. Now is the first balloon inflation in P2 level to the distal SFA. So
we did a 3-minute balloon inflation for the distal SFA to P2. 잠깐만 좀 이따.
And then we pre-dilate in proximal portion. And then we decide our further plan with the DCB or other stent.
So, Dr. La, you have many experience to treat the long SFA lesions. So, what is your opinion?
Some especially calcified very tough lesion, I prefer to do the prolonged balloon inflation with the long, pure non-compliant balloon, so that we can get optimal balloon response, and then decide provisionally whether to do. But balloon response is very nice, then we can finish with the drug balloon, drug DCB, or some bailout situation we can add on one bare metal stent. But these days in our country, there's a trend to maximal use of the drug technology for DCB for this native vessel. So it means that basically we need to do the prolonged balloon inflation for at least 2-3 minutes, and the balloon come down, then finalize with the DCB. Our Korean, we enrolled also the global DB impact clinical trial registry. Our Korean data shows that nearly a relatively higher rate of data outstanding, 1/4, 20 to 25% is additional stenting. So balloon response is not so good. Many operators tend to directly implant the silver PTS. If it's not so quite bad, then we try to do the DEB alone.
So, Dr. Schroe, how would you deal with this problem in Belgium, specifically with regards to, I understand the use of silver PTX in Europe in general is not particularly prevalent.
Well, I totally agree with what has just been said. For these really long lesions, these full metal jackets, we've proven till now that it doesn't have very good results in long term, and I think DCB with spot stenting or bailout stenting and to avoid large stent lengths is much better in long term than putting long stents in. Unless you consider Viaban as a good equivalent for these long lesions, but we're not used to do so. So I totally agree for DCB with bailout stenting for this lesion as well.
In Taiwan, it is very special that the Viaban graft stent is totally free. It's reimbursed for the patient. So no matter you use 2, 3, 4 Viaban, it's free. So in my country, for this kind of long SFA lesion, certainly we'll still do the prolonged POBA first. If the image is okay, then maybe we can consider DCB spot stenting, and if the lesion looks not good, just stent all the way with Viaban. And for patient, if we use Viaban, patient didn't have to pay anything. And then for long-term run, for such a 30-40 centimeter lesion, I think especially we have heparin coating Viaban, I think it's all right, but for the patient.
Are you used to using a lot of Viabans in the United States?
No, actually, I think the penetration of Viaban has diminished, at least in my practice. Increasingly, we're becoming all very much price sensitive. Viabans are all the way to the left with regards to price, particularly if you use several. To your point, I would agree that full metal jackets have sort of moved on, but at the same time, we understand that full metal jackets with silver PTX, if you put in 2 long silver PTXs versus several DCBs, plus minus 2 or 3 spot stents, you sort of start getting into the same price categories.
Well, actually, the price categories are the same, and I think till now we hope that the results are nearly the same, because, well, time will tell, but we don't have any data as comparing silver PTX with POBA to DCB with bailout stenting. There are no data.
Yes.
Okay, Dr. Lee, this is the final, or just
the pre-dilatation with the 5.0 to 200 balloon was done. As you can see, the relatively acceptable. How about
somebody needs a stent implantation for the proximal entry or distal re-entry point, or just DCB angioplasty will be enough?
Well, what does the panel think about that lesion at 34, 35? Should we do something more, or could we leave it that way?
Yes, this is to your point. Actually, I'm quite surprised and favorable with regards to this angiographic result. This area of recoil that you just called out to, that may be an area where you would put a 6x4.
Dr. Seung-Whan Lee, you already opened the Lutonix. However, they could not endure the system. Something draw coating eruptions. Anyway, you need to do some patience to gently insert the proximal portion, either the impact or the Lutonix. However, many interventions type A personality, difficult to.
4cm.
Yeah, you're right.
그만 가. 빼줘요. 좀 빼줄래?
빼줄게.
4cm, 3.5cm까지만. 좀만 가. 좀만 내려가.
By the way, do you have IVAS?
3까지 가, 3까지. 오케이, 거기. 오케이.
So now we apply the Lutonics 4.100 to 120.
Because there is a disease at the P3 portion, so we want to treat that lesion with a little bit smaller balloon, then we'll use a bigger balloon for this SF8 proximal.
So how about in US, you have some more different DB. So how about your experience in other DB, like not only this Lutonics and Paseo 18, Bio20 DB or any other DB? Do you see any difference in your clinical experience? DCB? Yeah, in US.
Yes, in the U.S., if we would use, what in the situation, the DCB? Well, I think, to tell you the truth, the penetration of DCB in the United States hasn't been as immediate as I think a lot of people would. There's still a lot of bare metal stents being used. For whatever reason, price particularly. I don't want to bring up this recurrently, but now a typical bare metal nitinol stent is $700. Having said that, we understand what the 3 and 5 year patency rates are, primary and TLR rates, which are not good, as you suggested.
My key question is, do you feel any differences in clinical experience among the different DCB, like a Pantera, the Paseo 18 DB, or this Lutonics, or Impact, or any other DB?
Well, I think in the absence of any clear data that drives medical practice,
comparison data.
People are all over the place. I can tell you, and I don't want to call anything out, but atherectomy still is actually emerging increasingly with the advent of DCB and this whole issue of vessel preparation. We've moved beyond pre-dilatation with a balloon to vessel preparation with an atherectomy device, buying into the hypothesis that if we debulk lesions, we may enhance the effect of a DCB. Now, that may be, I'm not saying this of my colleagues, that may be promoted by personal renewment and reimbursement, but that's the way things are moving in the United States, I believe.
Assuming that you have reimbursement for atherectomy, would you use atherectomy on these devices, on these lesions?
Well, we have put together a trial called Reality. 250 patients. We'll have 3 German sites, Dr. Torricello and Dr. Esring and Dr. Zeller, looking at just that question. So we're going to be doing atherectomy in long lesions, up to 25 centimeters, that are moderate to severely calcified with DCB and atherectomy before, in an attempt to find out what the reality is, what really happens to these patients. We're going to follow them out for 2 years. We'll have IVUS and angiography, duplex Doppler, and histology in the United States. In Germany, we'll just have angiography.
So this is another
we'll know.
DB. So 5 mil. Dr. Lee.
This is 5 or 120.
120. Lutonics DCB.
We may need 4 dB angioplasty for this patient.
오늘 내시 하나 더 드릴게요.
마지막엔 600일 수도 있어요.
So it's time to close. So what is your next plan? Just the DCB and wait and see, or other planning?
I hope the DCB work and without significant dissection and flow imitation. So I think the balloon dilatation more than 2 minutes with the DCB, maybe I hope make a good result. If some dissection and flow limitation, I put the spot stenting with the bare metal.
So even there's a mild dissection, if it's not flow limiting, I think it's better to leave it. And we can give the one chance to native vessel, and if there's another recurrence, then we can do something more with the foreign body. So hope you can find out with the DCB alone.
Why did you change your treatment strategy? You were a stent-holic for 2 years ago, 1 or 2 years ago.
No. I prefer the native to be native.
Okay.
Okay.
So, Dr. Lee, could you say to the audience to goodbye or something? This is the last.
Anyway, thank you
this is the last demonstration.
Our meeting, anyways, every year your coming is very happy to see you, and I want to see you next year, and I hope your health.
Thank you. Thank you very much.
Thank you. So we're going to switch back to Dr. Ando in the lab next door. Dr. Ando, are you there? Or maybe he's not.
Dr. Ando, yeah.
Dr. Ando?
Yes. I'll take a final image from here.
Yes, there you are. So maybe we have almost pretty much a minute left of transmission time. If you could show us what you've done and summarize your findings, please.
Yeah, so, yes, thank you very much. I only opened the peroneal and the popliteal artery, and I try to open the posterior artery if I can, but it's not so easy. But I considered the distal puncture, but I decided to stop here because the wound condition is not so bad.
How about anterior tibia? Because in your last image, it have a small channel. If you can replay the video.
So you can see dorsal pelvis artery here. So we can recognize both ATA and the PTA, but it's too much, I think, for him.
Yeah, I think we have to agree. At a certain time, you have to stop a procedure and think to take your patient back to theater, as for contrast, as for people getting worn out. But on the other hand, you have to consider to get something open to the foot. So take that bit.
This may be an opportunity to stage a procedure.
Yeah.
But, it looks, we'd like to thank you very much for your expertise and your commentary. I'd like to again thank the panelists likewise for some very insightful commentary, and wish you well. Thank you very much for the cases, and thank you very much for your attendance.
Thank you.
Very good. Thank you.
Thank you.